risk factors for cervical cancer, the greatest risk factor is infection with human papillomavirus, the wart virus, some people call it. And that's the major cause of most all cervical cancer. Not all, but most all. And that's acquired through sexual activity. So multiple sexual partners would be a risk for it. Early age at sexual intercourse would be a risk factor for it. Prior infection with human papillomavirus would be a risk factor for cervical cancer. And folks who don't receive regular and routine follow are at an increased risk for cervical cancer. Well, there is a great preventative measure now that is absolutely effective, and that's the new HPV vaccine. Well, not so new HPV vaccine that's been available for several years now. It's recently been improved to include 9 different high-risk or 9 different viral subtypes. So you can significantly decrease the risk of ever developing cervical cancer or even precancer, the cervical dysplasia, by taking that vaccine. And that's available for young girls beginning at age 8, even up through 26, and sometimes older. And for boys, I think right now the recommendation is to start them at 13, but they may change that down to a lower age group as well. In countries where there is a high incidence, or penetrance they call it, of the vaccine for HPV, they're seeing dramatic drop-off in the rates of cervical precancer, dysplasia, and cervical cancer. It's really, really, really effective because 70% of the cervical cancers, of the most common cervical cancers, are caused by 2 strains of that virus, and this vaccine is exceedingly effective in preventing infection with those 2 strains. Plus now they've expanded it even more, so you'll get more of the high risk, eliminate more of the high risk viral infections. So that's one way. The other way is follow your pap smears so that if there is a problem, we can discover it early before it's invasive cancer and treat it effectively, because we can prevent it from ever becoming a cancer. If you're talking about just a screening, if you're not having any problems, then I would still recommend a pelvic exam during your reproductive years every year. Obviously, if you're having a problem, you come in for a problem. You may not have a pap smear, but every 3 to 5 years, depending on what kind of pap smear is done. If we take the HPV with it, called co-testing, or if we use just a standard pap, that would be every 3 years. If we do co-testing, it would be every 3 to 5. And also that depends on whether you've had an abnormality or not. Those are screening tests. As you get older, and that starts at age 21. As you get older, some people age out. They end up having a hysterectomy for benign, non-dysplastic or cancerous reasons. So they don't have to have pap smears after they get to be 65 or after they've had the hysterectomy for benign disease. Some people still need to follow if they've had a hysterectomy and had severe dysplasia, say, or moderate to severe dysplasia. They'll still need to be followed, at least with an exam. Sometimes we do paps of the vaginal cuff. Not very frequently anymore. We look for an abnormality and then biopsy it if need be. Other people, there's still some controversy as when you can actually age out if you have an intact cervix. Most people will say if you've never had an abnormality, you can age out at age 65. Still, you'll need to come for an exam periodically. I would still say annually, to look for other things, diseases of the vulva, diseases of the vagina, do a biomanual to feel that there's no mass in the pelvis, find out if you're having any bowel or bladder problems, prolapse of the pelvic organs, things that we can help you with or fix. See if their hormonal status is okay, make sure there's no other problems ongoing. And then if you've had no abnormality, ever had an abnormal pap, maybe age out. If you've had an abnormality but have been normal for 20 years, then you can age out of pap smears at that point. But typically the pap part will be done at 3 to 5 year intervals. Pelvic exam at present, I would say at least age 65 done annually, and then it might skip to every other year. and certainly anytime there's a problem. The major screening tool for cervical cancer right now is a Pap smear, and we start performing Paps at age 21. People are a little concerned because we used to start those around the time of initiation of sexual activity, but we found that there's really such a low risk for cervical cancer in folks less than 21 years of age that it didn't make sense to do Pap smears and cause a lot of undue worry that there was a minor abnormality on the Pap smear and over-treatment, frankly, for some minor abnormalities that are destined to go away anyway. So now we wait till you're 21 years of age to institute screening for cervical cancer with the Pap smear. Certainly if people have abnormalities, pain or bleeding with intercourse, or notice a change in discharge even before age 21, we'll take a look there. But that's not screening. That's actual looking for or at someone for a problem. The role of the Pap is a screening test that says something may be abnormal. It doesn't mean that you have cancer. It doesn't necessarily mean there's really an abnormality there. And while the Pap smear can say, oh, this looks highly abnormal or it looks just a little atypical, the next step that we take is more diagnostic. Oftentimes now we test for the human papillomavirus along with the Pap smear. And if it's positive, then we may go to a more definitive test called colposcopy, where we look at the cervix under magnification and we look for abnormal changes on the cervix and the upper vagina. And then if we suspect anything, we can take a biopsy. And the histology, the actual tissue section from that biopsy, gives us a diagnosis. Sometimes we don't see anything, so we take a biopsy to prove that there's really nothing bad going on. Sometimes we have to take a larger biopsy, particularly if we have a Pap smear or a visual impression that disagrees with what the pathology comes back on a biopsy specimen. We might take a larger biopsy. The colposcopically directed biopsies are usually about 3 or 5 millimeters, so they're not real big pieces of tissue. If we don't have agreement or we suspect there might be more, or we're uncomfortable trusting the finding for whatever reason, we might then do a larger biopsy by taking an electric loop and taking that across the cervix and taking a larger piece of tissue out for the pathologist to look at, called a LEEP or Leitz procedure. Or we may take a cold knife cone, which is where we take a knife and actually remove a larger piece of the cervix for diagnostic and treatment purposes too, because both a LEEP and a cold knife cone will treat dysplasia, precancerous change, if it's there. And again, what we're trying to do is find things before they are cancerous and stop it before it progresses. Cervical cancer is treated dependent upon what stage the disease is. If it's early stage and confined to the cervix, or confined to the cervix and a small portion of the vagina, it's usually surgical treatment. And that's very radical surgery. It takes out the lymph nodes, it takes out a lot of extra tissue, more so than a routine benign hysterectomy would entail. Higher stages of cervical cancer are treated with radiation therapy and or chemotherapy with sensitizing agents and platinum-based therapy now. And sometimes some other new drugs are employed. And the treatment in early stage of even invasive cervical cancer is still has a very high success rate. And that's usually done by its subspecialty trained gynecological oncologist.